Mr. Jollimore.
Good afternoon, Mr. Chair, members of the Standing Committee on Health. I'm grateful for the opportunity to speak to you here on the traditional territories of the Algonquin First Nations. My name is Jody Jollimore, and I'm the Executive Director of Community-Based Research Center, or CBRC. My expertise comes from 15 years of HIV prevention, a master's in public policy, but most importantly as a gay man who has lived, worked, and loved in Nova Scotia, Quebec, and British Columbia. I'm lucky to be born in a time when it's good to be gay. I grew up with Will and Grace and Sven Robinson and, for the most part, gay marriage. By the time I had my sexual debut, life-saving medications meant that men like me were no longer being cut down in their prime by AIDS. But despite the immense political and human rights, despite these gains, our health outcomes, the health outcomes of all queer people, continue to be some of the worst in the country. My organization, CBRC, was started in 1999 as a response to HIV among gay men in BC. While we were founded for and by gay men, we made strides to include other sexual minority men, including bisexual, queer, cis and trans, and two-spirit people. Our nationwide Sex Now survey comprises the largest data set of this population, which continues to be an important source of information for policymakers and program planners. You see, while governments were trying to either ignore or, worse yet, erase our population, we were in the background quietly collecting data, developing reports, and talking about gay men's health to anyone who would listen. These days, we've increased our focus on public policy, recognizing that the kind of change needed is transformational and structural. For instance, we partnered recently with Canadian Blood Services to inform their policy change on blood donations for men who have sex with men. But before we talk policy, I want to tell you a story that I think contextualizes some of the struggles we face as a community. One of my best friends in high school was gay. He was a great friend and mentor to me. And we both left rural Nova Scotia to pursue our dreams. But my friend had always struggled with undiagnosed depression, and this worsened when we moved to the city. Despite being surrounded by more of his peers than ever, he continued to feel lonely, depressed, anxious, all very common issues impacting queer people, even in big cities. He self-medicated with substances and eventually started using crystal meth. Meth made him feel good. It made him feel wanted and accepted and part of something. It's hard to tell whether he was using meth or not when he contracted HIV, but I was with him the day he got his results, and we cried together. But we knew it would be okay because there were treatment options to keep him alive, especially in British Columbia. Only my friend didn't opt for treatment. Instead, he further isolated himself. He lost jobs, apartments, lovers, and friends because of his meth use. Left untreated, HIV becomes AIDS. And though it's rare in Canada, it does still happen, and usually only to the most marginalized and disconnected from care. So my friend died of AIDS in the late 2000s, despite there being free medications that would have saved his life. And my friend was not one of the most marginalized. Instead, like me, he was quite privileged. I'm white, I'm able-bodied, I'm cisgender, and I'm HIV negative. These all make me privileged, and yet, according to the Public Health Agency of Canada, the fact that I'm a gay man means I'm 131 times more likely to get HIV, 20 times more likely to develop an HPV-related anal cancer, and 4 times more likely to commit suicide. This is startling, yet this is what we consider a healthy, privileged gay man. So the bar is set pretty low. I listened to my colleagues' testimony from your last 3 meetings, and I was able to sit in on your meeting when you were in Montreal at Réseau. And I think the speakers have done a great job of setting the foundations for this study. By now, you know our health is not great. Across the board, physical, sexual, mental health, on all fronts, we fall short. And this is only what we know with the limited data we have. If we were truly leveraging the research and data tools within the federal government, we'd know so much more. So let's talk about what the feds can do about this. First off, my buddy had some mental health issues that were not being discussed at home or at school. Recent investments in mental health have been made, but they're modest and they frequently do not address the unique situation faced by queer people. Our mental health impacts so many other aspects of our health, and it's far more costly to treat the problem than prevent it. Treatment is almost always more expensive than prevention. So the Fed should increase their investment in mental health and earmark specific funds for sexual and gender minorities. The Mental Health Fund at the Public Health Agency is a program that could be expanded to include or mandated to target their funding calls towards organizations doing queer work. We also need to reduce stigma in this country. It's killing us. First, the stigma, fear, shame, they reinforce minority stress and trauma. But then that same shame and stigma then prevents us from accessing the services we need. And the result? High rates of HIV and STIs, high rates of substance use, depression, anxiety, and suicide. The federal government has the ability to impact stigma in several ways. First is equality under the law, and we're getting there, but there's still work to be done. Then there's the overuse of the criminal code on things like substance use, which we're seeing having devastating impacts on drug users in this country. Also, the criminalization of HIV non-disclosure. Both contribute to stigma in our communities. Then there's the Fed's role in education and awareness. The government sponsors social marketing around substance use, anti-racism, and healthy eating, so they could do more around sexuality and gender. It could be funded either using a health lens through Health Canada or an equity lens through women and gender equality. We also need dedicated funding. There are many examples of dedicated funding for various populations. The Harm Reduction Fund for drug users, the Mental Health of Black Canadians Fund, which is fantastic, but we need similar funds for queer people. Whether it be through the Public Health Agency funding or CIHR and their health centers, we need more dedicated queer funding for programs and research. And I know that you've heard this many times over the past few weeks, but we have to do something about the way we collect and use data in this country. That's a quick fix, but we also need to find innovative approaches to fill those gaps. I know this committee has studied pharmacare and made recommendations, but I want to make an additional plug, whether it be HIV meds, HPV vaccinations, or hormone therapies for trans people, a national pharmacare program would go a long way to improving access to prevention tools. Short of that, there are some creative ways the feds could fund treatments in provinces that don't cover them. For instance, federal funding has been used to help address gaps in provincial access to hepatitis C treatment, and the federal government could expand this strategy to ensure that queer people are able to access the medications they need regardless of where they live. And for me, that's the role of the federal government, to ensure equity and access for all Canadians, because queerness, or being a sexual minority, is not something that impacts just one community. It crosses racial, ethnic, religious, and political lines. Gays, lesbians, trans, and queer people are living in and coming from every community in this country, regardless of which riding you represent. So why should queer people have to move to the city to get the appropriate health care they need? Our data shows that the further outside an urban center you go or you live, the less likely you are to be out to your doctor. And we also know that if you aren't out to your doctor, you're 10 times less likely to be tested for HIV, much less receive the kind of health services you need. I was doing interviews in BC's interior, and after a long day, I stopped in a small town of Castlegar to grab some coffee. And that's where I met Todd. And Todd was a lively fellow, clearly gay, clearly out and proud. And I went into my community researcher mode and I started asking him questions. My city slicker attitude was like, what are you doing here in Castlegar? And his response was, Jody, I've been to the city. I did Vancouver and Calgary, and I always come back here. Castlegar is my home and I love it here. And I thought, this is why I'm doing this work. That's why this study is important. It's so that folks like Todd don't have to move to the city to be safe, to find competent health services, and to live free of discrimination. I want to share a quote with you, and then I'll wrap up, Mr. Chair. Over our history, laws and policies enacted by government led to the legitimization of much more than inequality. They legitimized hatred and violence and brought shame to those targeted. This was part of the government's apology to LGBT2Q Canadians in 2017. Chair, members, this is your chance to right some of those wrongs, to change laws and policies that continue to lead to poor health outcomes for queer, trans, and two-spirit people. I challenge you to do so, and I offer my organization's support and expertise. I look forward to talking with you about how we can make communities safer and healthier for queer Canadians. Thanks.